Tim's giving me the thumbs up here. Good afternoon, everybody, and welcome to Grand Rounds today. Today it is my pleasure to introduce Dr. Betsey Bean. Dr. Bean is an orthopedist and a hand surgeon. She did her orthopedic residency at Madigan Army Medical Center in Spokane or in Tacoma, and then did her hand fellowship at York Wellspring Wellspan in York, Pennsylvania. She's been on the staff here since August of this year and has kindly accepted the invitation from the CME committee to give us a review of upper extremity compression neuropathies. And please join me in welcoming Dr. Betsey Bean.
Well, thank you for that introduction. I am honored to be presenting today. I haven't been a part of the McFarland Clinic in Mary Greeley community for all that long, but my time here already has been great, and it's nice to meet many of you. Hopefully we'll have opportunities to meet the rest of the community in the future. So I'll be talking about common upper extremity compression neuropathies, and I picked this topic because it's so common. We see these patients all the time. And hopefully this will be a good refresher on the basics of anatomy, physical exam, and treatment options. So these are the objectives that you have received previously. We'll talk first about the histopathologic changes that are seen in compression neuropathies, and then we'll go into the four most common neuropathies that we see. I'm omitting a couple of some of the syndromes which are less common, like anterior interosseous nerve syndrome, and then two of the radial nerve compression syndromes, because we don't see those very often. There's just not enough time to talk about them. So first, for the pathophysiology, the spectrum of neural change that we see depends on the force and duration of compression. We'll do a quick refresher of nerve anatomy here, just to lay the foundation. So axons are the nerve signal goes through axons, and axons live within endoneurial tubes. Axons within their endoneurial tubes are grouped together into fascicles, which are lined with perineurium. And groups of fascicles make up a peripheral nerve, which is lined with epineurium. So initially, chronic nerve compression results in breakdown of the blood-nerve barrier. Next, you see edema within the endoneurium and perineurial thickening. You have an increase in endoneurial pressure leading to changes in the circulation in the nerve and decreased blood flow. And then the nerve becomes more susceptible to dynamic ischemia, which occurs in the upper extremity with changes in joint positioning and direct pressure over the nerves. This leads to local demyelination, followed by diffuse demyelination, which will result in slowed conduction velocity on electrodiagnostic studies. And then further compression will result in axonal degeneration or denervation of the nerve. And when that occurs, you'll see muscle atrophy and changes on your needle EMG. These changes aren't uniform across the nerve. What we see instead is that the location of degeneration depends on how the fascicles are arranged within the nerve. So in carpal tunnel syndrome, the superficial fascicles of the nerve are to the long and ring finger, and that's where patients often experience numbness first. Double crush syndrome is also important to remember when evaluating these patients. This is understood as the mechanism of nerve compression, of nerve compression at one level, which makes it more susceptible to damage at another level. In an antegrade fashion, it's hypothesized that axoplasmic flow will be compromised by proximal nerve compression and then further compromised if there's distal nerve compression. Reverse double crush can also occur, and this is where distal nerve compression leads to a decrease in return flow of neurotropic factors back to the neuron, and then the neuron doesn't send more factors distal to the nerve. And clinical studies have found associations between cervical radiculopathy, thoracic outlet syndrome, carpal and cubital tunnel syndrome, and animal studies also support crush syndrome and reverse crush syndrome. I won't spend much time talking about the cervical spine exam or crossover with peripheral nerve compression syndromes, but it is important to remember that and keep radiculopathy in your differential diagnosis. There are other associated conditions and patient factors that have been shown to contribute to the development of peripheral nerve compression syndromes, and it's best studied in carpal tunnel syndrome. We see associations with carpal tunnel syndrome and diabetes, hypothyroidism, excessive alcohol use, obesity, and tobacco. Work-related activity and its contribution to peripheral nerve compression syndromes is a little bit controversial, depending on who you talk to and what you read. But what we know is that moderate wrist flexion or extension will increase the pressure in the carpal tunnel and may place a patient at risk for developing carpal tunnel syndrome. And the same is true for elbow flexion, increasing the pressure in the cubital tunnel and possibly contributing to cubital tunnel syndrome. We will revisit this a little bit more later, but the American Academy of Orthopedic Surgeons, in their clinical practice guidelines published in 2016, they highlighted the association of repetitive hand and wrist motion and forceful grip, as well as assembly line work, computer work, and vibration with an increased risk of developing carpal tunnel syndrome. So despite it being somewhat controversial, there is evidence to support that certain work activities are risk factors for developing carpal tunnel syndrome. So now we'll move on to specific nerve compression syndromes, and we'll start with the median nerve. Anatomy is really foundational for understanding these syndromes, and so we'll start with a review of that, hopefully not too in-depth and boring. But the median nerve is formed by the terminal branches of the medial and lateral cords of the brachial plexus, and it has contributions from the C5 through T1 nerve roots. It runs deep to the pectoralis minor. It runs in the anterior arm compartment between the biceps, brachii, and brachialis. It'll run with the brachial artery at the elbow and cross over to be the most medial structure in the elbow, in contrast to the more lateral brachial artery. It will run under the lacertus fibrosus, and in most people it travels between the two heads of the pronator teres. The anterior interosseous nerve is the motor branch from the median nerve, and it'll branch from the nerve here, and then the median nerve continues distal and running under the fibrous arch of the flexor digitorum superficialis and between the FDS and the flexor digitorum profundus muscle bellies down to the wrist. In the wrist, the median nerve becomes very superficial, and it runs just under the palmaris longus tendon if patients have one. A lot of people don't have a palmaris longus tendon. The nerve is just superficial to the index finger flexor tendons, and it travels with 9 tendons in the carpal tunnel. Dorsally, the carpal tunnel is carpal bones, and then superficially, it's the transverse carpal ligament. Importantly, the palmar cutaneous branch is a branch of the median nerve, and it divides proximal to the carpal tunnel. It supplies sensation to it's the blue here, so to the thenar palm, and that will not be affected with carpal tunnel syndrome because it branches before and it doesn't run in the carpal tunnel. After the median nerve goes through the carpal tunnel, it has the recurrent motor branch, which goes to innervate most of the thenar muscles except for one. And then the remaining branches of the median nerve will innervate the index and middle finger lumbricals, which assist with metacarpal phalangeal joint flexion and interphalangeal joint extension, and then sensory innervation to the radial 3.5 digits. Dorsally, it'll innervate to about the PIP joints of those same fingers. So carpal tunnel syndrome is very common. It's the most common upper extremity compression neuropathy, and it'll affect 0.1 to 10% of the United States working population, depending on what literature you read. We see it 3 times more common in women, and it's very common in pregnant and nursing women as well. And it has a bimodal age distribution, so it peaks in the 5th decade of life and again in the 8th decade. Patients with carpal tunnel syndrome will present with intermittent paresthesias, numbness, and pain in the median nerve distribution. It's always important to ask patients where they feel numb and tingly, but my experience is most patients are not, it's difficult to localize that. It's difficult for our brains, especially when it wakes you up in the middle of the night, to figure out what's numb and tingly. Because the palmar cutaneous branch branches before the carpal tunnel, they shouldn't have numbness in the thenar aspect of the palm. Nocturnal symptoms are really hallmark, and this is primarily due to wrist flexion while we're sleeping. But there's also alterations in fluid balance when we're laying horizontal, which probably contributes. Patients often will describe improvement in symptoms if they rest their hand off the side of the bed or if they sit up. Daytime symptoms will occur during activities of wrist flexion and extension. A lot of times we see it while patients are driving or they're holding a book or holding their phone. And in more severe cases, we see intermittent numbness go to constant numbness, and then patients will develop thenar atrophy. They may have loss of pinch and grip strength. And patients will often complain of difficulty with fine motor skills because they simply can't feel things. They reach into their pocket and can't feel a coin or something like that, and that's called a stereognosis. For physical exam, sensibility testing is important. Sims-Weinstein, monofilament, and two-point discrimination are good objective measures of sensibility. Sims-Weinstein tests innervation threshold, and 2.83 monofilament is normal sensation. Anything larger than that is abnormal sensation, and that has very good sensitivity and specificity when you're evaluating carpal tunnel syndrome. Two-point discrimination is useful for testing innervation density, and less than 6 millimeters is normal. Strength testing for carpal tunnel syndrome primarily assesses the abductor pollicis brevis, and that palmarly abducts the thumb. So this picture is a good example of how best to assess the strength of that muscle. And patients with more severe disease will have weakness compared to the contralateral hand, so it's always good, obviously, to compare. Provocative tests will place an already compromised nerve, additional stress on that nerve, and so it'll exacerbate numbness and tingling and sometimes pain in the median nerve distribution. So Tinel's at the carpal tunnel, or just proximal to that along the nerve, should produce numbness, tingling, paresthesias into the hand distally. Proximal symptoms are not a positive Tinel's test. This is not very sensitive, so 50% sensitive, a little bit more specific. Phelan's test, holding the wrist in flexion, should reproduce numbness and tingling in the median nerve distribution, but again, not great sensitivity. And Durkin's test is just direct pressure over the carpal tunnel, which reproduces numbness and tingling. The most sensitive and specific test is the combined Phelan's and Durkin's, where you just do it at the same time. It's also the most efficient, so I tend to do that. The CTS-6 was developed by Graham and published in 2006, and in this study, they established consensus amongst clinical experts in the world of compression neuropathies on the most important clinical diagnostic criteria for carpal tunnel syndrome. They gave those criteria weighted values, and then they validated this diagnostic tool and called it the CTS-6. It consists of 6 clinical components with different point values, and 2 of these are subjective criteria and the other 4 are objective. The first is numbness predominantly in the median nerve distribution, nocturnal symptoms primarily, weakness or atrophy in the thenar muscles, a positive Phelan's test, loss of 2-point discrimination, so greater than 5 millimeters, and a positive Tinel's test. They then studied this diagnostic tool to evaluate how much electrodiagnostic studies add value to making the diagnosis. Obviously, if the diagnosis can reliably be established without electrodiagnostic studies, then we can save patients money, discomfort, and time. But I think our neurologists are fantastic. I use them all the time. But obviously, there are patients that probably don't need electrodiagnostic studies to establish that diagnosis. So who are they? In this study, published in 2008, they compared the probability of carpal tunnel syndrome being present when the diagnosis was established with either the CTS-6 tool or electrodiagnostic studies. And for the majority of patients who have carpal tunnel syndrome based on the CTS-6 tool alone, if they are very unlikely to have carpal tunnel syndrome or very unlikely to have carpal tunnel syndrome based on the score that you get, then electrodiagnostic studies do not provide additional value. If their pretest probability based on the CTS-6 tool is between 0.6 and 0.8, then nerve studies are very helpful for making that diagnosis, which makes sense because if you see a patient and every one of these tests is positive, think it's very likely they have carpal tunnel syndrome, and you get a nerve study and it says they don't, it's probably not going to change your diagnosis. And the opposite is true if they have very little that seems consistent with carpal tunnel and then they have a positive test. In terms of making the diagnosis, there are a few other important things to touch on. So these clinical practice guidelines, they evaluate the evidence for certain things. And in terms of confirming the diagnosis of carpal tunnel syndrome, there is strong evidence that thenar atrophy is strongly associated with carpal tunnel syndrome, but lack of thenar atrophy does not rule it out. There's also strong evidence supporting the use of multiple provocative tests instead of just relying on one, as we reviewed their low sensitivity. And moderate evidence supports not using MRI or ultrasound for diagnosis. However, there has been more research recently validating the use of ultrasound criteria for diagnosis specifically. And so we may see changes in the future with the application of ultrasound. This is kind of institution dependent, so it depends where you practice and what your radiologists are used to, though. Non-operative treatment is appropriate for patients with mild to moderate symptoms. If numbness is not constant, they don't have thenar atrophy, and there's no severe changes on electrodiagnostic studies, like no denervation or axonal loss. Nighttime wrist bracing, the wrist braced in a neutral position, should improve symptoms. And the type of brace is important because the goal is to keep the wrist in a neutral position, so soft braces aren't effective. Sometimes a brace with a metacarpal block that extends just past the MCP joints can be effective because it prevents full finger flexion, which draws the lumbricals back into the carpal tunnel and decreases space. But wrist brace just for sleeping, not daytime use. Steroid injections into the carpal tunnel should also improve symptoms. Results of bracing and steroid injections are variable. In one study, only 10% of patients remained asymptomatic at 1 year following either bracing or an injection, but other studies have shown longer-term relief with steroid injections. What we do know is patients with diabetes are 2.6 times more likely to experience recurrence of symptoms within a year after a steroid injection. There's some evidence to support that oral steroids can improve symptoms, but the evidence isn't as strong as a steroid injection or a wrist splint. This may be the most important slide in the talk because it's important to identify those patients who present with severe disease and are not indicated for a trial of non-operative management. Delaying surgery may lead to more permanent sensory and motor dysfunction. So surgery is indicated for patients with evidence of denervation or axonal loss, including those patients with thenar atrophy, constant numbness, and severe changes on electrodiagnostic studies, or if they fail to respond to non-operative management. And that's not highlighted yellow because that's an indication for surgery, but those aren't patients that there's an urgency to intervene on. There is also evidence to show that carpal tunnel release is beneficial for patients with severe disease, indicating it's probably rarely too late to see benefit from carpal tunnel release. This study evaluated patients with moderate to severe disease based on their electrodiagnostic criteria and found that patients with severe disease experienced considerable reduction in symptoms after surgery, but they may have a prolonged recovery and they may have incomplete resolution of symptoms up to a year after surgery. So I counsel all my patients that intermittent symptoms, particularly nocturnal symptoms, should resolve very quickly, but any constant numbness and tingling can take several months up to a year to improve. The goal of surgery is just to increase the size of the carpal tunnel, and when we do that by cutting the transverse carpal ligament. This can be done through open or endoscopic techniques, and both are effective at alleviating symptoms, and there's strong evidence to support surgical treatment of carpal tunnel syndrome has greater benefit at 6 and 12 months compared to non-operative treatment like bracing and steroid injection. This is just one study. It's a little bit older, but they randomized 192 hands into either open release or endoscopic release. And at least in this study, there's some evidence to show that patients had less acute postoperative pain, better satisfaction, and they returned to work faster. In this study, they got back to work at 20 days faster in the endoscopic technique than in the open cohort. Additional procedures that are not indicated include neurolysis, flexor tenosynovectomy, and lengthening or reconstruction of the transverse carpal ligament. These things don't show any added benefit over simple release of the transverse carpal ligament alone. This picture on the left is just a view of the transverse carpal ligament from an endoscopic approach. You see the transverse fibers there, and then the picture on the right is just the carpal tunnel wide open after release of the ligament. And it's also important to touch on treatment that the evidence does not support. So there's strong evidence to show that magnet therapy is not effective. There's moderate evidence to show that oral medications, including gabapentin and anti-inflammatory medications, are not effective. And additionally, postoperative immobilization is not supported, and this is discouraged because it can lead to scar entrapment after surgery. So moving on to the next topic. Pronator syndrome is a pain syndrome that results from compression of the median nerve in the proximal forearm and elbow. So from proximal to distal, these potential sites of compression that can cause pronator syndrome are compression under the ligament of Struthers. This is just a fibrous band that runs from supracondylar process to the medial epicondyle. Most people don't have a supracondylar process, but if you see one and they present with pronator syndrome symptoms, then it's something to be aware of. More distally, the median nerve can be compressed under the lacertus fibrosus, which runs from the distal biceps tendon to the medial forearm. The median nerve dives between the two heads of the pronator teres, where it can be compressed by some tight fascial bands. And then distal to the pronator, the median nerve runs under the fascial arch of the flexor digitorum superficialis, which is usually the last site of compression. Patients usually present with vague, achy proximal forearm and elbow pain. They may have numbness and tingling in the median nerve distribution as well. And in contrast to carpal tunnel syndrome, they should also have numbness in the thenar palm because the palmar cutaneous branch is affected, where it's not affected in carpal tunnel syndrome. Another important differentiating factor from carpal tunnel syndrome is that patients usually have more daytime pain. Nocturnal symptoms is not a hallmark of pronator syndrome. Symptoms are usually exacerbated by repetitive forearm pronation and elbow flexion. I had a patient that presented with these symptoms after spending a weekend ripping bushes out of her front yard, and her symptoms were really classic with pronator syndrome. The physical exam to evaluate for pronator syndrome has crossover with the carpal tunnel exam because we're still assessing the sensory and motor function of the median nerve. But other provocative tests include Tinel's at the proximal edge of the pronator. The pronator compression test is direct pressure over the proximal portion of the pronator teres, which should result in pain or paresthesias developing within about 30 seconds. Resisted pronation may produce symptoms as well. And then resisted flexion of the middle finger proximal interphalangeal joint can elicit symptoms if the nerve is compressed under the flexor digitorum superficialis. So how do you differentiate pronator syndrome from carpal tunnel syndrome? The few big things are that in pronator syndrome, these patients generally have achy forearm pain over the pronator. They also will have numbness in the palm, as we discussed, in the thenar eminence of the palm. And they may have negative carpal tunnel provocative tests like Tinel's and Phelan's and Durkin's, but that's not always true because there can be some patients that present with both pronator and carpal tunnel syndrome, especially if you believe in double crush syndrome. Unfortunately, electrodiagnostic studies are not helpful in most cases for pronator syndrome, so it's truly a clinical diagnosis. There isn't a lot in the literature reporting on how often we see carpal tunnel and pronator syndrome together, but a couple of studies that I found show anywhere from maybe 6 and 12% of their patients presented with both. There's probably more patients that we are missing the diagnosis because we're not looking for it. Non-operative treatment is appropriate for most patients at initial presentation, and this consists of occupational therapy for nerve gliding exercises and flexor pronator muscle stretching, along with activity modification. Steroid injections have been described, but are difficult to do because there's not one potential space like the carpal tunnel. There may be several areas where the nerve is compressed, and so it's difficult to know where to inject the steroid. There are a few small, mostly older studies that report benefit of non-operative management, mostly with activity modification. Surgery is indicated for failure of non-operative management after about 3 months, and there's different described techniques, but the primary goal is just to decompress the nerve at all potential sites. And again, outcome studies, there's very few of these, but most show that the majority of patients get better with surgery. A few have complete relief, and a few have no relief. So we'll move on to the ulnar nerve and a couple of compression syndromes for that. To begin with anatomy, so it's the terminal branch of the medial cord of the brachial plexus, and it has contributions from both the C8 and T1 nerve roots. And it runs down the medial arm, just about 8 centimeters proximal to the medial epicondyle. It will travel deep to the internal brachial ligament. This is also known as the arcade of Struthers, which is different than the ligament of Struthers, but named after the same Struthers. This is a tight fascial band from the medial triceps to the medial intermuscular septum. At the cubital tunnel, the nerve runs deep to Osborn's ligament, and then distally it passes between the two heads of the flexor carpi ulnaris, travels deep to the FCU muscle belly down to the wrist. And at the wrist, it travels through the ulnar tunnel, also known as Guillen's canal. And the ulnar nerve is superficial and ulnar to the carpal tunnel. It doesn't run in the carpal tunnel. Just into the ulnar tunnel, it'll divide into a sensory and motor branch. At the elbow, there are occasionally some small branches to the ulnohumeral joint and possibly a sensory branch to the posterior elbow, but classically the first branch that's described is to the flexor carpi ulnaris, just distal to the cubital tunnel. It innervates a couple of muscles in the forearm, just 2 really, and then in the hand it does the majority of the motor work of the hand, excluding most of the thenar muscles. And then it provides sensation to the entirety of the small finger and the ulnar half of the ring finger and the dorsal ulnar hand as well. There is a dorsal sensory branch to the ulnar nerve that branches before the wrist, and it travels to the back of the wrist to provide innervation. Important to note that the medial forearm is not innervated by the ulnar nerve. It comes from the medial antebrachial cutaneous nerve, which is a different nerve off the brachial plexus. So that comes into play when we're evaluating patients' distribution of numbness. So cubital tunnel syndrome is ulnar neuropathy that localizes to the elbow. We discussed the primary sites of location a little bit. So just above the elbow, sometimes the medial intermuscular septum can also be a compressing force, especially in patients that have big, strong triceps. I think it squeezes the nerve against the intermuscular septum. And then Osborn's ligament at the ulnar tunnel, and then distally it can be compressed at the flexor carpi ulnaris. And patients present with pain and paresthesias in the ulnar nerve distribution in the hand, including the dorsal ulnar hand, but not proximal to the wrist. Sometimes it can be difficult to determine if there's a peripheral nerve compression syndrome or if patients have radiculopathy. So when you're evaluating for cubital tunnel syndrome, it's always important to keep in mind that a C8, T1 radiculopathy can present very similarly, but those patients should have numbness that is into the medial forearm. And symptoms start as intermittent, and they're exacerbated usually with elbow flexion and direct pressure over the cubital tunnel. In advanced disease, numbness becomes more constant, and patients may experience intrinsic muscle weakness. It's usually described as clumsiness by patients or weakness and cramping in their hands. Inspection in comparison to the other hand, which is hopefully normal, is very important. So we inspect for atrophy of the interossei muscles, and particularly the first dorsal interosseous, which is easiest to appreciate. The Wartenberg sign is the inability to fully adduct the small finger, and that happens because the third volar interosseous muscle is weak. So the extensor digiti minimi, which is innervated by the radial nerve, pulls the finger into abduction. Clawing of the small finger and ring finger can also occur in advanced cases because all of the intrinsic muscles to the small and ring finger are weak because they're innervated by the ulnar nerve. And so you have this imbalance between those weak intrinsic muscles and the extrinsic muscles that are innervated by the median and radial nerves, and they cause this clawing deformity, which is less seen in the index and middle fingers because of a different innervation pattern. Sensory exam is, of course, important and should also evaluate the dorsal ulnar hand. Motor exam is mostly just finger abduction against resistance. Froment's test evaluates the ulnar innervated adductor pollicis. So a normal test is when patients can keep their thumb interphalangeal joint flat when they're pinching between the thumb and the index finger. If they flex the thumb interphalangeal joint, then they're using the flexor pollicis longest to hold on to whatever they're pinching because their adductor is weak. And then Tinel sign at the cubital tunnel is useful. Elbow flexion compression test, which is just as it sounds, elbow flexion, maximal flexion, and then pressure over the cubital tunnel should also reproduce numbness and tingling in the small and ring finger. And then it's also important to evaluate for ulnar nerve instability, which is just done with palpation over the cubital tunnel and elbow motion, and you can sometimes feel the nerve subluxate over the medial epicondyle, which can be really irritating to patients, and sometimes I think they present with cubital tunnel syndrome in normal electrodiagnostic studies as well. So other diagnostic tools include electrodiagnostic studies, which can be useful mostly for confirmation of diagnosis, but it has been shown to lack sensitivity. High-resolution diagnostic ultrasound has also shown to have similar sensitivity and specificity to electrodiagnostic studies, and what we're looking at in the ultrasound is the cross-sectional area because it will increase as there's more severe neuropathy, specifically when there's axonal loss. An MRI can also differentiate normal anatomy from focal areas of compression, and some studies have shown it to be nearly as accurate as electrodiagnostic studies, but it can also show some downstream muscle injury in chronic cases if you are able to include like the forearm in the elbow MRI. Again, we don't use these modalities very often here, at least, just institution dependent, but some places it's more regularly used. So the goal of non-operative management is to alleviate the pressure and tension on the ulnar nerve, and there's evidence to suggest that these things are beneficial in mild and moderate disease. Most of the non-operative management is just patient education. So educating patients to avoid resting the medial elbow on hard surfaces like desk workers or patients that drive for long periods of time that rest their elbow on the window or the armrest. Avoiding activities that require elbow flexion for long periods of time. And I see this a lot because patients are holding their phone up constantly or maybe reading a book for a long period of time, and then they notice that their small and ring finger go numb. And then avoiding heavy or frequent triceps exercises, again, probably we see this more in young males that have really large triceps and maybe have ulnar nerve instability, and that can exacerbate it. An elbow extension splint that's worn while sleeping can be helpful. There's plenty of off-the-shelf splints like this one in the picture, or occupational therapy can make a custom splint. The cheap way to do it is to wrap towels around the elbow and tape them in place just to prevent elbow flexion while sleeping. And interestingly, corticosteroid injections have not been shown to be effective when compared to placebo in a couple of randomized double-blind studies. There have been other studies that show maybe some short-term benefit, but in contrast to carpal tunnel syndrome, where we use them a lot and there is good evidence for that, they're really not all that useful for cubital tunnel syndrome. You also need to have ultrasound guidance for those injections to do it safely. Operative intervention is indicated when symptoms fail to improve with non-operative management, or patients present with severe disease, like wasting in their intrinsic muscles. The two basic surgical options are to decompress the nerve where it lies and leave it there, or transpose the nerve anteriorly. Decompressions can be done open or endoscopically. Transpositions can be done subcutaneously or within the muscle or deep to the muscle. And all techniques work well, and studies have failed to demonstrate superiority of one over another. Some studies suggest a small difference in postoperative complications, though, and transpositions seem to have more acute postoperative pain. They are more likely to have paresthesias on the posterior elbow and slightly higher risk of postoperative hematoma, although most of these differences will resolve within about 8 weeks after surgery. So the last compression neuropathy we'll cover is ulnar tunnel syndrome, which refers to ulnar neuropathy at the wrist. The ulnar tunnel is also called Guillen's canal. The ulnar nerve travels with the ulnar artery, and it runs deep to the flexor retinaculum or the volar carpal ligament, but it's superficial to the transverse carpal ligament, which forms the floor. On the ulnar side, you have the pisiform, the flexor carpi ulnaris, and the abductor digiti minimi, and then the hook of the hamate is the radial border. Once the nerve enters into the ulnar tunnel, it will divide into sensory and motor branches, and the motor branch will dive deep, and it travels under this fibrous arch called the pisohamate arch, which can sometimes cause compression. And in ulnar tunnel syndrome, it's important to remember that the dorsal ulnar hand is innervated by the dorsal cutaneous nerve of the ulnar nerve, and so it won't be affected with ulnar tunnel syndrome. Symptoms depend on which portion of the nerve is compressed. So initially, the ulnar nerve is a mixed motor and sensory nerve, and then it divides. And there's 3 zones which correlate to which portion of the nerve is in each. So compression proximally will result in both motor and sensory symptoms. Just distal to that, we see more motor symptoms as the motor branch is compressed, and classically a ganglion cyst will cause compression of the motor nerve. And then distally, compression of the nerve will just cause sensory changes, and that may be more likely with ulnar artery aneurysm or thrombosis. So other causes of ulnar tunnel syndrome, classically this patient is a carpenter who uses their hand as a hammer, or a cyclist who spends a lot of time resting on handlebars. We talked about ganglion cysts, which can also contribute, and then wrist fractures can sometimes be a factor, especially if the hook of the hamate is fractured and displaced. And idiopathic causes can also occur. A lot of times it's just a tight pisohamate arch that may cause just motor symptoms. Physical exam for ulnar tunnel syndrome consists of many of the same things that we previously talked about, that evaluate for muscle atrophy in the ulnar nerve innervated muscles, as well as sensation in the ulnar nerve distribution. And Tinel's over the ulnar tunnel can sometimes be useful, but it seems relatively non-specific. I wasn't able to find any literature on that, but anecdotally for me, it's relatively non-specific. Allen's test is also important to rule out abnormalities, as ulnar artery thrombosis or aneurysm can cause ulnar tunnel syndrome as well. X-rays are recommended if the history is right. So if there's a history of trauma, X-rays can be really useful, or CT scan specifically if you're looking for a hook of the hamate fracture. MRI can be useful for evaluation, especially if you're looking for a ganglion cyst. Electrodiagnostic studies can also be helpful to localize the site of compression, especially if your physical exam is a bit inconclusive. And then angiogram may be useful if your physical exam is concerning for an ulnar artery abnormality. Non-operative treatment consists of modifying activities that will eliminate the exacerbating factors. So for cyclists, this is generally just changing hand position with their handlebars or getting padded gloves. For carpenters, obviously, stop using your hand as a hammer. In contrast to carpal tunnel syndrome, there's really no evidence that splinting or corticosteroid injections are helpful. Operative intervention is indicated when non-operative treatment fails, or if there's a known mass in the ulnar tunnel. And ulnar tunnel decompression is done through an open approach, and outcome data is limited with small case series that usually show improvement following surgery. So, in conclusion, anatomy is the foundation to being able to perform a thorough physical exam and make the correct diagnosis. And remember that it's rarely too late for patients to benefit from surgical decompression, especially in carpal tunnel syndrome. These are just some pictures of my time in the Army with very unsterile surgeries in a battlefield setting. So I appreciate your time. Hopefully this was helpful, and I'm happy to take questions if there are any, and please feel free to contact me if I can be of assistance. With diabetics, what's the chance of good results for ulnar transpositions? I don't know of any studies that specifically look at, this is from Dr. Kitchell, that specifically look at outcomes in diabetic patients. I think that I think that surgery is potentially beneficial for patients that have cubital tunnel syndrome. So yes, I think it can benefit them, but I don't know of any specific studies that look at outcomes if they're worse with diabetics. I think it just depends on how bad the compression neuropathy is. All right, thanks.